So good afternoon, all the speakers, the panelists, the viewers from Physio TV. We are live online now. I'm handing over this session to Dr. Farheen.
Good afternoon to all the viewers of Physio TV. I, Dr. Farheen Patel from Sancheti College of Physiotherapy, Pune, would like to welcome you all to the webinar on pelvic floor by Dr. Nilima Bedekar and Dr. Kari. Before we start, I would like to introduce our esteemed panelists, Dr. Snigdha Mehta and Dr. Preetha A. Dr. Snigdha Mehta has of experience in treating women with different problems like incontinence, pelvic pain, bowel dysfunction, etc. She is a certified obstetric and physiotherapist. She is also a trainer of antenatal and postnatal. She has trained many physiotherapists nationally and internationally in obstetric physiotherapy. Her physiotherapy center has been nominated among the 3 best physiotherapy centers in Mumbai in 2 years back to back, that is 2019 and 2020. And our second honorable panelist, Dr. Preetha A, is an associate professor at Manipal University with 18 years of experience. She is PhD in women's health and is an internationally certified childbirth educator. She has many publications under her name, and she has spoken on many webinars and sessions on the topic of antenatal and postnatal physiotherapy. We would also like to thank our driving force of the institute, our founder, President Dr. K.H. Sancheti, sir, our ever-inspiring chairman, Dr. Parag Sancheti, our dynamic executive director, Mrs. Manisha Sangvi, and our always encouraging principal, Dr. Vivek Kulkarni, sir, for providing this awesome platform. Now, I will hand over the session to our panelists. Thank you.
Thank you, Dr. Farheen Patel, for that kind introduction. Good afternoon, one and all. It's my privilege to welcome our first speaker of today's session, Dr. Nilima Bedekar. Dr. Bedekar completed her BSc PT from GMC Nagpur, MSc from UK, and PhD from Pune University. She's currently the professor and HOD, Musculoskeletal Physiotherapy, Sancheti College of Physiotherapy, Pune. Madam is a recognized PG PhD guide, and she has been the former member of Academic Council, PG Board of Studies, Research Board, and Chairman UG Board of Studies at MUHS Nasik. She has her expertise in women's health, yoga, and electrotherapy. She has over 30 publications to her credits in various national and international journals, and she has conducted presentations in several national and international conferences. We wholeheartedly welcome you to deliver your talk on the topic, pelvic floor testing and training. Over to you, ma'am.
Thank you. Thank you so much, Preetha ma'am. So we'll begin the session for today. 1 second. Her screen. Oh, yeah. So what I'm going to talk today is the pelvic floor muscles, treating, testing, and training. So it's going to be very basics today. I thought that to begin with, because there is so much to learn into this area. So what I'm going to discuss today is what is the need to do the testing of these muscles? What are the associated problems or risks which have a problem with the pelvic floor muscle or a strain on it? Who needs the evaluation and training? And what are the simple and sophisticated methods to check the muscles? And how do we train and enhance their function? So we all know that there is a need as the life cycle changes in a woman's life, and early detection is the key to treat the person properly. We all know that we need to keep active, we need to keep fit and do the exercises, but areas like pelvic floor are still neglected, and we need to highlight this problem to the whole society benefit because 50% are women. So once we identify and timely manage, we can give better results. As the external stresses on the muscle and the internal environment also causes so many problems. So from here, the women even don't come forwards. So that's a problem. And hence we need to identify and do it as early as possible. So there are few areas of concern that we need to identify. So one of it will be women having engaged in a high impact activity, women who go into a lot of weight lifting and other things, women, one second, who have to return back to active sports, and women having difficult childbirth, multiple childbirths, and so much and so forth. Women with overweight and obesity, with aging, there are so many changes, also various habits. So all these women come with problem to the muscle. Who should be tested? So it is pelvic floor muscle dysfunctions. It's a big area. Amongst it, we must check that if it is an overactive, that needs a specialized area. Otherwise, for stress incontinence and for laxity, we can treat. But again, sexual dysfunctions and other things, we need a specialization. But we can do a basic testing for them, and then we can take help and refer these patients. Now, my basic primarily thing is also to let know physiotherapists working in musculoskeletal area that the low back pain, pelvic pain, now chronic pelvic pain again needs a specialization area, but we do treat low back pain patients, sacroiliac joint dysfunctions, women coming with laxity or connective tissue disorders, rheumatoid arthritis, women having osteoporosis have a high correlation with pelvic floor muscle laxity, or women returning to high impact activity or sports. So that's an area if having a long-term illness or a surgery or a difficult pregnancy or a surgery into the pelvic area, and they're returning back, they go into doing a strengthening protocol, but this muscle is neglected. There are areas where respiratory diseases, we need to take care of that because that's not going to keep us trained continuously for years together. Of course, neurogenic involvement needs a special attention differently. It's very important how we are going to test. So without history, we don't go further. History tells us a lot of what is happening. So any patient coming to us with low back pain, we basically just screen them honestly and ask them about what happened. Just in 2 minutes, we can get some idea about it. Because the minute if we say directly that we want to check your pelvic floor, they might not come back to us saying, oh, this is something very different. So it will take few years for some people to realize about it. But we can always do simple observations or visualization. So I would always recommend that whenever we find, we do check the core, transversors in supine, prone, all those. But once we find that there is an area of concern and the person is not able to activate, we shouldn't wait, but we should do an external palpation, hands over panties, but in a close proximity, so that we can feel of what is happening at the pelvic floor. So that is not very, very ideal. The next way is we could visualize. So we could ask the person to address and visualize. So once we do that, we can have a gloved finger and just see the area and visualize the perineum. So we can check if the correct contraction is occurring. We can check whether the person is able to relax so that the neuromuscular control, if it is there or it's lacking. So we understand how quickly the contraction occurs and the relaxation occurs. So same as how we are going to do an internal vaginal examination, we will ask them that we are going to test how strong your muscle is. So try as if to stop the urine flow. So there are so many ways to ask them to tighten and contract the muscle. So we'll ask them whether you pull in and up, and we will see whether you're able to do that. So once that is done, we can just see the external muscles are going to contract, but when we see that the perineal lift is there, definitely it cannot happen without the internal muscles tightening. So we can keep a record of that and we can check how many second hold or the fast contractions. So we can do that. Though it's a very crude method that can guide us whether we need to go further and do an internal. We can also check during this time whether the person is doing more concentrated efforts on the pelvic floor or it is the adductor and other muscles contracting more than it. So we make a note of all this. If the person is not very ready, we can ask the person to do a self-visualization by using a mirror and do it herself at home. Now, doing urine stop test, we recommend only for a few very well-educated women, but that can also be done. So we all know that internal vaginal examination is the gold standard, where we can actually palpate what is happening into the tissues. We can feel for the wall laxity. We can feel and check right and left whether equally are happening. We can ask the person to tighten the back passage and see what is happening to the puborectalis. So we can feel each area. And that also gives an idea about how much laxity, how much control, whether there is internally any adhesion formations and so on and so forth. So we had the Oxford grading. So here the pelvic floor muscle testing, we do in a different manner. As the MMT, we don't do it against gravity. We do in a gravity eliminated position and we add the slow hold or the endurance to it. So the most recommended method is the perfect, which has been come through different areas. So initially it was only the gradation, then came with Mantle and Polden, adding the part that able to hold for 5 seconds, 7 seconds, and so on and so forth. So I was very lucky to get guidance directly by Jill Mantle. So she just explained it at that time, and it was very great to work with her, under her. So we can ask them to do a self-assessment in that way. Whereas Lecoq had even, so if a specialized person can do it on a 0.0 to 15, 16 grades. So the internal vaginal examination can go into so much details. So what happens is we get a basic idea about how is the muscle strength, endurance, whether how is the neuromuscular control. So all this subjective method is having a good reliability validity. But it's extremely important, I find, having some method of having an objectivity to it. So I love EMG biofeedback. There are tests, there are many um, publications on all this. Manometry is one of the best method. Perinometer is a simple equipment. So many things can be done with it. Vaginal cones, personally, I don't like them because that itself has a problem using it, or if extreme laxity is there, we may not get the correct strength, but still that is being used by some. So I think Kari has a study saying they are not having a good correlation. So that's one study where I came across and I said, yes, they don't have good correlation. But all this is going to give an idea of what is happening to these muscles in an objective manner. So plus we can do that in against gravity and various positions. So we can't do manual muscle testing in the positions, but with these equipments, simple equipments, we can do it against gravity and functional positions. So possible to do it in sitting, standing, and so on and so forth. So that's the best part of adding these objective methods to it. And we'll go through. There are, of course, ultrasound is there, which is non-invasive. But in India, physiotherapists are not allowed yet to use. So hopefully that can be area. So we need to take help. Currently, we take help from the consultants to get this checked. But other organs can be looked into. MRI, and if NCVEMG is required, that is one when they are going to talk about getting surgery. So we'll get an idea on the assessment of what is the muscle status. We have to have a good judgment in order to start with the program. So if we find that the muscle is in spasm, if we find amongst, so we need to categorize further. So we have to see what symptoms the person is coming with. So it's not just directly starting with the training as a pelvic floor exercise. We have to see whether the pain, spasm, what has happened, if the pelvic pain, especially chronic pelvic pain area is there, which we don't start working with pelvic floor exercise as such. So we do test, But we all know that pain is going to have a compromise effect on the strengthening part. So there are a few areas where we have to check out before we start the exercise. Yeah, one thing I missed on, there are a few contraindications and there are a few precautions who should be tested internally. So I don't recommend, unless we are doing a research or we have a good expertise, to do an internal vaginal examination. We can do an external visualization and give them the exercise. Immediately post delivery or post operative, we should not be doing an internal vaginal examination. So that's very big area where we need to check whether any contraindications or some precautions before testing. Once we have a guideline that yes, it is grade 3, the person is able to sustain for 7 seconds, is able to repeat for 2 or 3 times. So if the person is not able to hold for 10 seconds, I don't go for repeat of the endurance, because at times that can give a delayed onset of more soreness in the first place, and the person may not remain compliant and feel that, okay, this has caused me more problem. So be judgmental about the analysis, and we keep a record that how many fast, how quick they are, see for the safety. Respond to the range of the contextual factors the person has, because we all know that there is a continuation of the sexual area into this domain, and there are so many problems. I'm not highlighting all the sexual problems of women over here. They come to us very rarely at times. So we need to encourage all that practice, which is a very specialized area still. Patient education and internet is one big educator. So we need to keep ourselves abreast and updated, and we need to find out whatever is there, if it is applicable and correct. So they might come to us that these are available. What can you do this? So we have to always keep abreast about it. So we enhance this training by using stimulation, checking for if that is required, if the muscle is extremely weak. Also, this strengthening program follows the PIT principles. So we have to tell them that they have to be really doing it with great practice initially, at least few weeks. If the muscle is extremely weak, we ask them the number of times the person has to do will be more. As the muscle gains strength, it can be reduced. So number of times the person needs to do exercise. So it's a prescription we have to do depending on each individual. This one area we have to check what is happening to the breathing and what is happening to the other muscles of the core. Because we all say that this is a part of the core. So we should always find out that what is happening with the breathing techniques. They have also found out, there is an EMG study by Hodges et al. That as we know that, okay, transversals are checked and they are acting before the limb loading or extreme activity or exercise with the limb. Same way they have done with using the vaginal electrode and the biofeedback, that before the activation of deltoid and shoulder abduction, strong abduction, the pelvic floor muscles did contract first. So that timely action and that reflex should be checked for. So for that, all these techniques can work very well. Also the core connections, this study in 2019 is done on males, and they found that giving the respiratory exercises or the abdominals had an influence on pelvic floor muscles, but it's done on males. But it's very interesting study. Again, I love the EMG biofeedback, and this is the anonymous dual channel EMG biofeedback unit. So once the person is able to see, these are the number of fast contractions, and this is the strength, this is the slow hold. After 6 weeks, this person came with stress incontinence. This was the muscle for her, and she was very impressed, and she could connect to it. So we can train them that, okay, tighten, now let go. So connection to the muscle improves with such a feedback. It can be pressure or whatever. Again, there is one more with dual channel. If we have, we can check and deliberately activate and enhance the function by using other muscles. So if the person is not able to sustain, there we will give an overflow by resisting adductors with a great precaution that once the muscle is able to isolate, the person is able to isolate, then we should train well. So keeping dual channel, one on pelvic floor, another on transversals. so on and so forth. So we can see it at two areas at one time. So two channel. So at times we can give the strengthening protocol at the same time. For some, the gluteal activation will enhance the pelvic floor. So we just told that tighten the gluteal muscles, and this is what happened automatically. The person didn't even think about it. So we can do so many things with some feedback mechanism. So we check what is the muscle strength, and we can assess the strengthening with the stimulation. If we have advanced equipments, we can use feedback with stimulation, or pressure with myofeedback, or only stimulation. There are so many things. Our women, they don't like to have a unit of themselves because at times they may not have so much of a privacy. So we cannot have a strict protocol. It depends on how much they can afford, whether they have a room, whether they have this privacy to do so many things. So we need to do all this and check. So this is one, yeah, disposable tampons as a visual biofeedback. And this study I found was interesting in a way. They used EMG biofeedback initially to check the strength. And then they asked these women, they were having no problems, so normal individuals, or with symptoms of stress incontinence or laxity. So they were given a training using a tampons, inserting, and at home to see the mirror and see the tampon end, how much it is going in and inwards. So they could do the correct indrawing technique and doing sustained contractions, looking at the mirror at home. So just using a simple tampon, it worked so well. So I've not done that on patients yet, but can try that. So there are so many new things coming up. One more thing I would like to highlight, and there are two things in yoga. So Mulband is one and Ashwini Mudra is another one. And I'm very happy that actually the pelvic floor muscle, exercise, training, all this has a roots from yoga and two Chinese practices. And I have read that in the Chartered Society manuals on pelvic floor and training. So I was quite impressed, and I became more inquisitive about this, because after practicing yoga also, I was not aware about this Mulbandh and Ashwini Mudra till my anatomy professor explained, and she's an expert in yoga. So it's a very subtle contraction of the perineal muscles of the anterior front passage. So it's only a gentle activation and no more. So they say with doing this bandh, it's the perineal body, just focus on that and just activate and tighten. As we know, if we have a cord and we activate and the systems start working. So there are many contonations in yoga about it, but as a physiotherapist, we can train women. So if they have a choice, see, we have to offer them different choices. So if they are doing some yoga, we can say that you can do this. So we can get to know after a dialogue that, okay, what they like, because it is a very slow sustained contraction and they have to repeat. And I do like this, and I had actually used this for using the pelvic floor muscle activation during singing. So for meditation, for a controlled breathing, breathe out, marvelous way. So Bulban, great activation. Can activate the front passage differently, back passage differently. So we should take help. One thing about doing other pranayam techniques, only Mulbandh is not going to support. For this Kapalbhati pranayam, it has to start from a strong pelvic floor contraction, tightening in, then the transversals, and then the pranayam or the breathing technique. So if it is any post expiration, we need to first check whether the person is able to activate the pelvic floor muscle correctly. Because it goes that, okay, I have started doing yoga and I start pranayam. And women postnatally, they can start with all this without having a knowledge of what is happening to the pelvic floor muscles. So that is one area where we can train them and make use of that. Ashwini Mudra is a very strong contraction of the anal sphincters. So it's very strong and can be activated very well. So these two need an attention, and we can talk to the women who like to do that way. So we can offer so many things. So grade 3+ onwards, we can give different ways, the lift technique, tighten the muscle, lift up as if going upwards on the lift. So each muscle is going to get activated from external to the internal. Same way, coming back down with the eccentric control and coming the relaxation. Understanding relaxation is equally important because otherwise that can lead to more spasm and a problem. So we should make them understand that this is what you are relaxing and that's the correct way. So we want then eventually the muscle in isolation, discrimination, and we can check them and train them in various positions. It can be loaded as with the other core. So it's really good to see a woman getting a good contraction and good activation of the muscles. So this is one part where so many problems can be corrected, such as stress incontinence, pelvic organ supportive function, sexual functions, if they are in a different way due to laxity, there are problems that they don't feel the sensation. So in that area, definitely this is going to work. For women with coordination with the core, with the transverses, with the breathing, and so on and so forth. So there are different positions where we work with core and the breathing. So it's a complex area where the coordinated action with the other core muscles can function well. So with this technique and improved function, the pelvic spine stability is going to work well. Prevention from recurrence of low back pain can be there. So we integrate. The beauty of it is the integration of the reflex action back. We don't even think while doing and strong contraction of the limbs. Our pelvic floor is going to get activated. But if that reflex action is lost, then strengthening, we aim to put this reflection action and timing back into function. So that's the way we want to happen it naturally because we can't ask them every time to contract. So neck and other things continuously cannot be done. But once that strength and endurance is there, we check if that reflex action is integrated. So that's the best way to see that integration happening and the person doesn't have to think again. So that would lead to improvement in performance, having the good quality of life coming back. So person can enjoy. There are 50% of the population suffering with so many things and keeping quiet about it. So I think it's our duty to check and go forwards in going and approaching the whole society and vital needs. There are many women and therapists working for this. So never forget, do screen them well, see what is needed for individual person, prescribe and change that prescription, have a follow-up and see that, yes, training shows the reversibility. So we get back the function well. Involvement of the person, of course, is mandatory. And that's our skill that we need to find out more exercial ways so that the person will doesn't have to think too much about the exercise part. How many of us like to do exercises continuously? So we need to identify more ways. There is more research coming up, and I'm sure women will enjoy more, and it's our role. We will see that we keep ourselves updated with the new developments. So for students, till now in our syllabus, we have only theory part. If at all you want to do an internal vaginal examination, see that you get trained personally under supervision first, because there are a few areas we don't want to do unnecessarily without a supervised practice. So get trained, theoretical knowledge is there for you, and you can use this in practice under supervision. And once you are, then you're okay to prescribe these exercises and get over the dysfunctions. So these are my references. The list is there for you. And a big thank you, the panelists and Dr. Kari and Farheen. So thank you again, everyone. So I would like to end my talk for today. So this is back to you, Farheen. I'll stop sharing my screen.
Thank you so much, Dr. Nilima Pedekar, ma'am. I would like to hand over the session to Dr. Stigna Mehta. Over to you, ma'am.
Today, I have great pride in introducing to you one of the greatest physiotherapists and an exercise scientist of our times. She completed her PhD in 1990 and was appointed Professor of Exercise Science in 1997. She was the first Vice President of Women's Health Section of WCPT, Vice President of Sport Physiotherapy Subgroup of Norwegian Physiotherapy Association, and VC of the Norwegian Council for Physical Activity, giving direct advice to the Norwegian Minister of Health on physical activity, fitness and health. She has published more than 290 peer-reviewed scientific papers on pelvic floor dysfunction, incontinence, low back and pelvic girdle pain, exercise during pregnancy and after childbirth, diastasis recti abdominis, fitness and women's health, and has given more than 300 invited international keynote presentations worldwide. She has supervised 19 PhD candidates and has 8 PhD candidates currently under her supervision. She has published numerous articles, videos, and books about the pelvic floor, fitness, pregnancy, and physical activity, and women's health in general for the lay public. She oversees the postgraduate course for physiotherapy for pelvic floor dysfunction on behalf of the Norwegian Physiotherapist Federation since the early 1990s and has given numerous postgraduate courses for physiotherapists internationally. She is appointed by the Swedish government as board member of the Swedish School of Exercise and Health. She has been a visiting fellow to Stanford University, USA, a visiting professor at University of Dunedin, New Zealand, University of Melbourne, Australia, Ministry of Health, Singapore, George Institute for Public Health, Australia, Bristol Urology Institute, England, Monash University, Australia, Auckland University, New Zealand, and University of Sao Paulo, Brazil. She has been an honorary member of the subgroup of Women's Health for Norwegian, Brazilian, and Chilean Physiotherapy Association. In 1989, she developed the Norwegian Aerobic Fitness Model, an 80-hour course for aerobics instructors, and a 60-minute exercise class for health-enhancing training for women. She still holds those 2 exercise classes per week at her local sports club. In 2014, one of her randomized controlled trials on pelvic floor muscle training was ranked and awarded one of the 15 top trials in physiotherapy among more than 25,000 studies in the Pedro database. In 2015, she was awarded with the Mildred Elson Award, the most prestigious award from WCPT, for her contribution to research and education in pelvic floor dysfunction and women's health. In 2016, she was awarded the International Continence Society Lifelong Achievement Award. In 2019, she was awarded as an honorary member of the Norwegian Physiotherapy Association for her work for physiotherapy in Norway and worldwide. As if this was not enough, this multi-talented genius with so many accomplishments is also a jazz and contemporary dancer and a rhythmical gymnast. She has taken part as a sport model, showing Norwegian sport clothes in a dance and gymnastics show in Las Vegas, Germany, and in France. Today, we are privileged to hear her talk to us on physical activity, good or bad for the pelvic floor. With great pride, I would like to welcome the unstoppable, highly skilled, and ingenious physiotherapist, Professor Kari. Welcome to you.
Thank you very much, Dr. Mehta.
That was a very long presentation, and I must say it's a long time since I was a dancer and a gymnast, so that's some time ago. Anyway, it is my background, so that's for sure. Good afternoon, everyone who is listening to this, and I will start to also thank the organizing committee and all the members of the panel for inviting me. I'm very happy to be with you all, and I understand that there are a lot of people now listening to us, and I hope this will be a good session. I had hoped to see you all in person in India, but due to the virus and the pandemic we have to do this online, which is better than nothing. But I personally would like to see all of you and to discuss more in person in the future, so hopefully we can do that. Thank you also for inviting me to give one of my favorite talks, which is on physical activity, or whether this is good or bad for the female pelvic floor. So this has been my interest since I started to work in this area in 1986. So this has been a long time. So I'm working at Norwegian School of Sports Sciences that you can see here. We don't have the snow yet, but it will come. And then I'm also part-time working at the Akershus University Hospital in gynecology and obstetrics. And this is mainly for research purposes. So I just want to give this disclaimer first, so you can all read that. And then let's start with some definitions. Physical activity is any bodily movement produced by the skeletal muscles that results in a substantial increase over the resting energy expenditure. This can happen during transportation, during work or at school, during household or other chores, and during leisure time with sport and fitness activities. And this is usually what we are thinking about when we're talking about physical activity, but it can happen in all these other areas, and all these other areas can also affect the pelvic floor. So exercise then is leisure time activity that is usually performed on a repeated basis over an extended period of time, and we call this exercise training, with objectives as improvement of fitness, physical performance, or health. Fitness, on the other hand, can be both cardiorespiratory fitness, strength, flexibility, and motor components, including balance and coordination. So Hippocrates, long time ago, said that all parts of the body which have a function, if used in moderation and exercised in labors in which each is accustomed, become thereby healthy, well-developed, and age more slowly. But if unused and left idle, they become liable to disease, defective in growth, and age quickly. Of course, this is the truth, but today we also have evidence for a lot of this. So according to the physical activity guidelines for Americans, published in JAMA in 2018, they listed that physical activity lowers the risk of all-cause mortality, cardiovascular disease mortality, cardiovascular disease, hypertension, type 2 diabetes, adverse blood lipid profile, cancers of bladder, breast, colon, endometrium, esophagus, kidney, lung, and stomach, dementia, anxiety and depression, falls and falls-related injuries, and it improves cognition, quality of life, sleep and bone health, and physical function. It slows or reduces weight gain, weight loss, and prevent weight regain. Hence, exercise is really medicine, and it should be used as medicine as well. And according to the WHO Global Recommendations on Physical Activity that was published in 2010 and will be updated, it's coming now hopefully before Christmas, physical activity inactivity is the fourth leading risk factor for global mortality, with 6% of deaths worldwide. Physical inactivity levels are rising in many countries, with major implications for the prevalence of non-communicable diseases and the general health of the population worldwide. Therefore, adults aged 18 to 64 years are recommended to do at least 150 minutes of moderate intensity aerobic physical activity, or at least 75 minutes of vigorous intensity aerobic physical activity throughout the week, or a combination of the two. For additional health benefits, increase the moderate intensity aerobic physical activity to 300 minutes or engage in 150 minutes of vigorous intensity aerobic physical activity per week or a combination of the two. And muscle strengthening activities are also recommended to do major muscle groups strengthening training on 2 or more days a week. And this is ongoing, so we cannot stop and think, well, this was enough. Exercise is something you have to have fresh. You have to do it throughout your life, either you like it or not. So therefore, it's important to find something that we find that is interesting and that we want to do as part of our life. I think the pelvic floor is the only area of the body where we can ask, is physical activity good or bad? In 2004, I proposed the two opposite hypotheses on exercise and the pelvic floor, and this was further elaborated with more evidence in a publication from Ingrid Nager and me that was published in Sports Medicine in 2019, and you can see all the evidence also for this talk in that publication. So the first hypothesis is that general exercise training strengthens the pelvic floor muscles and narrows the levator hiatus. This may lead to less urinary incontinence, anal incontinence, and pelvic organ prolapse. But it may also have a negative influence on vaginal birth. The other and total opposite hypothesis is that general exercise training overloads, stretches, and weakens the pelvic floor and opens the levator hiatus. And this would then lead to more urinary incontinence, anal incontinence, and pelvic organ prolapse. But on the other hand, then it would also perhaps give easier birth. So let's go through some of these evidence for these assumptions. If we look at the impact on the pelvic floor during physical activities, the normal response theoretically would be that with no or little downward movement, with closure of levator hiatus, with little need for contraction of the pelvic floor muscles. The pelvic floor would be up there and tight and stay there. A dysfunctional pelvic floor, on the other hand, would be too much downward movement and opening of the levator hiatus with inadequate response of the pelvic floor muscles. And this may be due to low anatomic location of the pelvic floor, weak connective tissue, a large levator hiatus dimension, low cross-sectional area of the pelvic floor muscle, which may negatively affect the strength, coordination, and timing or speed of the pelvic floor muscle contraction. These are all hypotheses, but I think that is the theoretical framework that we should work when we are doing research in this area. So if we look at the maximal vertical ground reaction forces during activity, this was published a long time ago by Hay in 1993. And they found that with running, there was 3 to 4 times the body weight, jumping 5 to 12, landing from a front somersault, 7.9 times your body weight, double back somersault and the landing again 14, a long jump takeoff 16.4, and as you can see in this Norwegian Olympic gold medalist Trine Solberg, in javelin throwing in her lead foot, there would be about 9.1 times her body weight, and this all has to be transferred to the pelvic floor and withstand also by the pelvic floor. Ground reaction forces has also been measured in the more recent study from Miller and McCraw, and they measured drop landings from 30, 60, and 90 centimeters heights investigated in 10 female gymnasts. And the result showed that it was the range from 27.1 at 30 centimeter landing to 56 Newton per kilo at 90 centimeter. And we know that the gymnasts are landing from more than 90 centimeter. So they had to really withstand a lot of high ground reaction forces as well. And Also, the intra-abdominal pressure, that has been more focused than the ground reaction forces, actually, when it comes to the pelvic floor. And there are many studies that have tried to look into this with different methodology. And you can see here that the intra-abdominal pressure during abdominal exercise and lifting varies a lot, both between each participants and also between studies and the different activities, as you can see here. From the plank and to light lifting, there is a huge overlap in what happens in the intra-abdominal pressure. So the difference among studies are in performance of exercises, the definitions used to define the exercises, the measurement methods, and the population studies. So very, very difficult to really conclude on this for the moment. This study, though, is very important because they looked at the intra-abdominal pressure during physical activity, and they had 30 women performing 3 repetitions of different activities. And the measurement of intra-abdominal pressure was done with a microtip rectal catheter in this study. So the results show that abdominal crunches, climbing stairs, walking on a treadmill, and many lifting activities did not increase the abdominal pressure significantly more than standing up from a chair. And we wouldn't ask women to not standing up from a chair, but we are asking women not to do abdominal exercises. And I think that we shouldn't do that, because this study, at least, and there are other studies going in the same direction, that the intra-abdominal pressure during abdominal crunch is not that big. And also the same has been tried to be done during cough and aerobic exercises. And again, you see the same pattern, a huge overlap between these different activities. And again, the same problem here. There is a difference in performance of exercise, the definitions used, measurement methods, and population. So I would say it's very hard to conclude on this. We know that when we are doing activities, intra-abdominal pressure is rising. But is it good or bad for the pelvic floor? We don't know. And it's very interesting because physiotherapists have been concerned that there should be some exercises that are less, have less negative influence on the pelvic floor. And in this study, they had 53 asymptomatic women, mean age was 39 years, and they compared 10 pair of exercises controlled for age, BMI, and parity, which was very good in their design. And this found that there were significant differences in treadmill, running versus walking, in cycling, standing versus sitting, cycling, with lunges with wide or with weights versus narrow, shoulder press, and step-ups. But there were no significant differences in ball, rotations, lunges, core exercises, push-ups, and squats. So they concluded that performing the recommended pelvic floor safe, or what they thought was pelvic floor muscle safe exercises, may not necessarily protect the pelvic floor, and vice versa. So again, we have a lot of assumptions and a lot of thinking and theories about this, but we need more evidence. And I really welcome more studies like this, looking at what's really happening when we are doing these exercises. This is what we need. Of course, there is a limitation in this study because it was done on asymptomatic women, so we need to see this also in those with the symptoms, what happens to them. That would be a very important study to continue with. The big question, I think, is can pelvic floor muscle response be measured during physical activity? And we just heard an excellent talk by Dr. Bedeker about that it was possible to measure with different measurement methods, which of course we can. This is the wish of everyone, but is it possible to do these measurements otherwise than what Dr. Bedeker said? Well, because that was in a controlled situation, but during physical activity, this is what we want to measure, but is it possible? And this has been tried for many years. It started, I think, what I found from England with Dr. James in '78. I think he was the first to try to measure this during physical activity. And Constantino, one of my coworkers in the US at Stanford, he has tried to do this during coughing, not exercises, but coughing. And we tried to do this with the ambulatory urodynamics back in '94. We gave up because it was not possible, I think, to really analyze the results we have. There was too much disturbances and artifacts in the studies. And then this group from Switzerland has also tried for many years now to use surface EMG and to measure this during physical activity. However, the problem is with all of these different devices that we have tried to use, and we wish they would work, is the movement of the device. Because when we start jogging or dancing or doing exercises, we are moving, and this device will also move inside the vagina or the rectum or the urethra. And then the problem with pressure, that's what we have used a lot. Are we actually measuring the intraabdominal pressure, or are we measuring the pelvic floor muscle response? And this has not been solved as far as I know. There is an upcoming apparatus from Jenny Kruger at the University of Auckland in New Zealand that has promising results, but we haven't really tested that during strenuous activities yet. So that has to be seen. And surface EMG is very, very complicated because there are crosstalks from nearby muscles, and the same group has really developed and tried to do all these studies from Switzerland. They also concluded that crosstalks from nearby muscles is a problem. It is unclear whether this issue can be solved with today's technology. So when you see in the literature, you can see that there are reliable results, meaning that when we are measuring it twice or with two physiotherapists measuring the same phenomenon, we get the good results, and the reliability is good, but it's not perhaps valid because we may be measuring other things than what we want to measure. And this is the big problem. So we have to take cautions when we are looking at study, presenting what's happening during physical activity. And especially if they want to measure the response of the pelvic floor muscles, I don't think it's possible to say that accurately for the moment. Unfortunately, I really wish we could do it, and I hope we can, but it's going to be very, very difficult to do because of the location of the pelvic floor inside the abdominal cavity. You can't take it out and just look at the pelvic floor. So everything is influencing at the same time. So to go on, does one bout of 90 minutes of heavy general exercise cause pelvic floor muscle fatigue? This was the question from one of my master students. And we looked at heavy strength training and high impact endurance activities. 90 minutes of very hard activities compared to a resting period in a crossover study. And we found that there was a 70% reduced maximum voluntary contraction of the pelvic floor muscles after 90 minutes of strenuous exercise. However, there were no change in endurance or vaginal resting pressure. In another study that I was able to find in this area, they looked at one bout of exercise, and this was 35 healthy nulliparis CrossFit women compared with 35 recreationally active women, and the mean age was 24.8 years. They did one bout of 20 minutes of CrossFit exercise or walking. The results show that there was an increase in both groups in maximal vaginal descent and decrease in vaginal resting pressure. However, compared to our study, there were no differences in pelvic floor muscle strength or maximum voluntary contraction after this bout of exercise. So again, only 2 studies, we need more knowledge in this area. So do exercising women have a stronger pelvic floor muscles? Well, the theory would be that there will be a stretch shortening cycle during any activity or a co-contraction with other muscle groups. This is, of course, very difficult to study because what about genetics? Because there are the genetic background in any woman who choose different sports. So we can't be good in any sport. So you choose what you are made to do. And then there is a selection to specific sports, of course, also in the musculature and how the pelvic floor is working. So very hard to find out about this. So there are a few studies finding that there are stronger muscles in athletes, and this study from Brazil showed that 49 high-impact athletes have stronger peripheral muscles than controls. And in another study from Brazil, peripheral muscle strength correlated with aerobic capacity and frequency of exercise. I must say, though, that in this study, the aerobic capacity was not measured in the best or most valid way. However, there is also a study from Borin and co-workers in 2013 looking at 10 volley and 10 basket and 10 handball players versus 10 controls. And they found significantly weaker peripheral muscle between the volleyball and the basket and the control group, but not the handball and the control group. And they found, as many of other studies have found, that low peripheral muscle strength correlates with symptoms of urinary incontinence. There are, however, also many studies finding no differences and no association between exercise and peripheral muscle strength. So I would say we don't know this yet, whether you can get stronger in your peripheral muscles by doing irregular exercise training without contracting the pelvic floor muscles at the same time. We don't know that. There are some studies also on peripheral morphology, and here they compared female athletes and controls. This was 10 athletes and 10 age-matched controls, and they used MRI. The results showed no difference in size of the pelvis, which of course were a very important finding. So you couldn't claim that the pelvic floor were wider or bigger in any of the groups. And there were no difference also in the urogenital hiatus in the study. However, they found that the cross-sectional area of the muscle levator ani was 20% higher in the athletes. But again, we must ask the question, is this inherited? Is this the genetics because they choose athletics because they can, or is it due to the exercises they have done? And then pelvic floor function in elite nulliparous athletes versus control. They went on with this study, and this study they used ultrasonography and looked at 24 nulliparous elite athletes compared to 25 age and BMI matched controls. And the results show that there was a higher muscle diameter in the athletes, which was the same as they found in the former study, so really confirming that. But they also looked at levator hiatus area on Valsalva, and that was higher. So it was not any restrictions on the levator hiatus. So it was wider than in the other group. And there was greater bladder descent on Valsalva also in the athletes. No significant difference on hiatal area at rest or during pelvic floor muscle contraction, though. So, do women who exercise have less or more urinary incontinence? The very definition of stress urinary incontinence is complaint of involuntary loss of urine on effort or physical exertion, example given sporting activities, or on sneezing or coughing. So, physical activity may unmask the condition that will not be there if you are inactive. Continence relies on maintaining urethral closure pressure, and this can be done by activation of striated and smooth urethral muscles. Submucosa with prominent vasculature has to be in shape. What about the estrogen level? This is very controversial. We don't know much about that. The resting tone and the contraction of the pelvic floor muscle also may play a role. And then again, degree of downward movement and opening of the urethra during exercise. So, do we find less urinary incontinence in exercising women? Epidemiological studies find that physically active, mainly walking, women report less urinary incontinence. However, these are based on cross-sectional studies, and there is a selection bias because we know that women with stress urinary incontinence, they drop out of exercise, so they stop exercising. Hence, are they dry in these studies because they exercise, or can they exercise because they are dry? This is a theoretical scientific question that we always have to pose. And if there is an effect of exercise on urinary incontinence, does this go through weight reduction? Because we know that overweight and obesity also is a risk factor for urinary incontinence, and if you exercise, you are likely to be less obese or less overweight. Contradictory to this, that we think that general exercise is good for the pelvic floor, we find a high prevalence of urinary incontinence in women participating in regular physical activity. So in this study from Norway, 31% of sports students versus 10% of sedentary students reported urinary incontinence. So this was statistically significant. In women with stress urinary incontinence, 2/3 of sedentary women reported urinary incontinence to be the main reason for withdrawal in this study. And 33% of exercises in a study from Ingrid Nygaard in 1990 also reported urinary incontinence. And Brown and Miller from Australia found that 40% of mid-aged women exercising had incontinence and 30% avoided sporting activities due to urinary incontinence. 15% of young and middle-aged women in non-competitive sport reported urinary incontinence in Italy, and 49% of exercises in Austria reported urinary incontinence. And very interesting, 26% of group fitness instructors and the same in Pilates and yoga instructors were found in this Norwegian study having urinary incontinence. And 24.6% of nullipers women attending gyms versus 14.3% of controls reported urinary incontinence in this study. And 49.3% among women attending gyms and exercise classes in this study as well. So women who exercise also leak. And if you go to the elite athlete studies, and we now have studies from all over the world, from almost all sports that are in the Olympics and in other areas, the last one coming from rhythmical gymnasts from our group in Norway, you can see a huge number of women reporting that they are leaking during sporting activities. So it's very unlikely, in my head at least, that exercise would do that you are not leaking. This is really evidence for the opposite. There are also studies that has compared exercises versus controls, and you can see that the odds ratio or the risk of having incontinence about 3 times that of those who are not exercising. But does this matter in the long term? In this follow-up study from Ingrid Nygaard again on former US Olympians, they didn't find any difference in urinary incontinence between gymnasts and track and field athletes versus swimmers who are not exposed to high intra-abdominal pressures 20 years afterwards. And in this 15-year follow-up from our group in Norway of former elite athletes and controls, we found that former elite athletes were not more likely to experience urinary incontinence later in life compared to controls. Former high-impact activities did not influence prevalence of urinary incontinence later in life. That was the same as Ingrid Nygaard found. But urinary incontinence early in life experienced during sport was strongly associated with urinary incontinence later in life. And this also corresponds with other studies, finding that if you have incontinence early in life, this is a risk factor also to have it later in life. So what about anal incontinence? There are few studies in this area. In this study, athletes were compared with controls, and there was a significantly higher prevalence of anal incontinence in the athletes, but also to be very much emphasized that 84% of this was flatus. In a study from Brazil, there were no differences, but a high prevalence between athletes and controls. And in this internet survey of 311 female triathletes, 28% reported anal incontinence. And in our study that is just about to be published now, 80% of strength and Olympic weightlifters in Norway, more than 70% reported leaking. 80% reported anal incontinence, with more than 70% reporting leaking gas only. And also we asked here the male weightlifters, and 61.8% of them also reported to have this. But interestingly, the men didn't bother about this, but the women, they felt that it really influenced their sporting activities. So what about pelvic organ prolapse? There are a few studies on pelvic organ prolapse. In this study from Norway, 49 women with pelvic organ prolapse stage more than 2 was compared with 49 women with 0 or stage 1. And we found that heavy occupational work was associated with pelvic organ prolapse, but low intensity physical activity was not. Ingrid Nygaard found no association between odds of pelvic organ prolapse and lifelong leisure or strenuous activity, but there was a non-linear significant relationship between teen strenuous activity of more than 21 hours per week, so that would be the athletes in that study. 5% of 311 female triathletes reported pelvic organ prolapse symptoms in this internet survey, and there were no POP symptoms in 67 athletes from Brazil. But again, from Norway, in our latest study, 23% of female power and Olympic weightlifters they were feeling a bulge within or outside the vagina. So again, difficult to conclude. Can high impact activities then cause pelvic organ prolapse? To this, we need prospective studies, and this study was very interesting with 116 nulliparous women with a mean age of 20.7 years. They were examined with pelvic organ prolapse with a POPQ and questionnaire before and after 6 weeks of summer military training in the US. And they found that female paratroopers, this was a small group, but now it was 37 of them, they were significantly more likely to have stage 2 prolapse and worsening of the pelvic support, regardless of initial prolapse stage. And this was assessed with ultrasonography. In this study performed at a university hospital before surgery for pelvic organ prolapse, they found more severe pelvic organ prolapse after 1 hour of structured exercise in women planning surgery. And there is an urgent need, in my opinion, for prospective studies in this area. So what about effect of exercise during pregnancy on the fetus, labor, and delivery? And this, now I'm talking about general exercises. There are several systematic reviews in this area, and it has been found that birth weights of exercising women are less likely to be more than 4,000 grams and not at increased risk of being less than 2,500 grams, which is good. Exercises does not increase the risk of preterm birth. Exercise is not linked to risk of induction, epidural, episiotomy, or perineal tears, forceps, or vacuum delivery. First stage of labor before full dilatation may be shorter in exercising women, and exercise throughout pregnancy may reduce cesarean section. And this is conferred in the latest study from Iceland with 248 Icelandic primiparis athletes and controls. There were no adverse effects on delivery outcomes. So this indicate that there is no negative effect on the birth canal from general exercise. So what about this is a study from Norway. Do that first. Does general exercise during pregnancy affect the levator hiatus area? Was our research question in this study. We looked at 300 nullipara pregnant women, and we defined exercises as those exercising more than 3 times per week. When we looked at those reporting to do pre-pregnancy exercise, there were no significant difference in levator hiatus area at gestational week 21 or 37. Those who were exercising at gestational week 21, there was again no significant difference in these parameters. However, looking at those who were exercising at gestational week 37, and this you would imagine are the real exercises because they are really close to birth and they are still doing general exercises. They had significantly larger levator hiatus area, so not any constriction of the levator hiatus area. And then the question has been, can you be too tight of doing pelvic floor muscle training, and should you not do that during pregnancy, because that would may have some negative impact on the birth. So this systematic review by Du and co-workers was on 13 randomized controlled trials, and they found that pelvic floor muscle training significantly shortens the first and the second stage of labor in premi-gravida women. And antenatal pelvic floor muscle training does not increase the risk of episiotomy, instrumental vaginal delivery, and perineal laceration in premi-gravida women. So I hope that we can all join together and try to abandon this myth that you get too tight to give birth by doing pelvic floor muscle training during pregnancy. It's probably not true. So, can pelvic floor muscle training treat urinary incontinence in athletes? We know that there is one A-level evidence or recommendation for pelvic floor muscle training to treat and prevent urinary incontinence. There is only one RCT on athletes, and this one was on 32 volleyball players from Brazil. They did pelvic floor muscle training for 3 months, and this was compared with the control group who only had a pamphlet of information. There was a significant improvement in favor of pelvic floor muscle training in pad test and frequency of leakage in the pelvic floor muscle training group. But we have only one RCT, so here we need much more evidence. So to round up, is physical activity good or bad for the pelvic floor? This is difficult to conclude, as you understand from the data I have presented to you. I would say physical activity is only good if the pelvic floor can counteract the increase in intra-abdominal pressure and ground reaction forces. And we don't know who can do that, so we need to investigate that. The pelvic floor needs to be like a firm trampoline, not a slack trampoline. It has to be firm and to be able to withstand all these pressures. Physical activity in itself does not protect against urinary incontinence, anal incontinence, or pelvic organ prolapse. Exercise increases 3 times the risk of urinary incontinence. Physical activity can therefore not be used as an intervention to reduce urinary incontinence in women who leak during physical activity. And this was also presented at the ICS in 2019 in a very high quality RCT showing that it was no effect of adding general exercises, in this case running and jumping, to a pelvic floor muscle training program. There is some evidence that physical activity can cause and worsen pelvic organ prolapse. Do exercising women have weaker or stronger pelvic floor muscles? I don't think we can conclude on that for the moment. They do have larger or may have larger cross-sectional area of the pelvic floor muscle, but at the same time they have larger levator hiatus and more descent. Physical activity and pelvic floor muscle training have no negative effects on labor or birth. And there is some evidence that general exercise and pelvic floor muscle training can reduce first and second stage of labor. So, need for future studies. In my opinion, we need to look at the effect of pelvic floor muscle training on stress urinary incontinence, anal incontinence, and pelvic organ prolapse in strenuous exercises. Can we treat them? The mechanisms of heavy exertion on the pelvic floor, we need much more basic research here. We need prospective studies of women starting regular exercise training to see what happens to the pelvic floor. We need to look at the impact of strenuous exercise on the pelvic floor in early postpartum period. Please, anyone, look into that. This is an important research area. But don't forget, exercise is medicine, and no one should stop exercising. But exercising women also need to train the pelvic floor. This is the message. And then just to present and thank my research group in Norway, and also thanks to my good collaborator in the US, Ingrid Nygaard. So thank you so much for the attention, and I look forward to discussing these things with you. Thank you.
Thank you so much, ma'am. It was an honor to hear from you. I would like the panelists to open the question and answer session.
Stigda ma'am? Yeah.
Okay. That was a wonderful talk, Kari and Dr. Bedekar. I was just wondering, if a young girl comes to me for advice and says that which physical activity should I take up seriously so that my pelvic floor doesn't suffer, what would I advise her? Kari and Dr. Bedekar, what would you say to this?
I wasn't sure I got the first part of your question. What was, could you repeat it, please?
Yes, sure. If a young girl comes to me and asks me, what kind of physical activity should I take up so that my pelvic floor doesn't suffer in future, what can I advise her?
I don't think we can advise on that. I think in general that we should be very happy that young girls want to be physically active. That's the first. And we all want to encourage all of that. Most women would not have a problem during physical activity. If they recognize that they have a problem, then I think we should teach them to do pelvic floor muscle training, and hopefully that would help. We don't have the evidence, but I think it may be helpful because they haven't really tried it. We have now a lot of evidence showing that they don't know about the pelvic floor, they never heard about the pelvic floor, the coaches doesn't teach them about it. So the potential for them to, if they have a problem, to be healed is huge, in my opinion. So I think it's a combination, and I think we should never ever advise not to exercise, because the problems of being inactive is so much bigger than being active and have a few drops of leakage. Because if you look into these studies, it's very little. It's not a huge amount of leakage. It's small drops, and I think it can be prevented by using, for instance, tampons or other things to try not to have it, and also the fact that they can learn how to do pelvic floor muscle training.
Yes.
Just
I feel,
sorry,
yeah.
yeah,
I
sorry,
feel we
Dr.
don't have enough evidence in the long term, because if genetically they are not predisposed to any laxity or anything, they could be very stronger. So yes, I also can't say for sure, but if they are engaged in dancing, we must see that whether general laxity they have. So if they are prone, they should do a general strengthening. That's what I feel.
Right. So should we examine the pelvic floor, do you think, before they, or they train them for pelvic floor before they take up a physical activity seriously? Would that be a good idea?
I don't think so. Because once we become aware, then that also sometimes is a bit of hassle. So if they don't have any symptoms, if they're completely asymptomatic, then it's very natural to get engaged in sports, and the pelvic floor muscle is also going to get contracted. So it happens if there is some trauma or some problem with the pelvic floor, that it doesn't get back directly normally. Because there are so many women suffering and they get back into function without any dysfunction. So it's very hard to prove in the long term what will happen. But I don't think at the beginning we should be doing any assessment if there are no symptoms, I feel.
I agree on that, and we have to be very careful, because I'm working a lot now with the rhythmical gymnasts, and they're very young. And what we have done to assess them is that we are using suprapubic ultrasonographies. We are not going into the vaginal area, of course. I mean, these are 13, 14 years old. And there has been terrible situations in gymnastics, as you may know, with this American coach that were really sexually abusing gymnasts. So we have to be very careful in what we are doing in this area. So, but suprapubic ultrasound functioned very well. We can't measure actually the strength, but we can see that they are doing it correctly. So we had both the mothers and the fathers came with us when we did it, and they were very thankful, because they hadn't recognized that their children had this problem. So they were very thankful, and it helped a lot that we tried to do this, but we haven't succeeded to do the randomized control trial yet. We had started it, but then the COVID-19 situation came. So we have to, I think we just have to stop doing that. RCT is not going to work, unfortunately.
Thank you so much. Preeta?
Yes, Dr. Kari, having understood the importance of physical activity and also the posture as such, because posture also has a role to play on the dysfunctions of pelvic floor. We understand that. Do you think that it's important as a physiotherapist to do a foot evaluation or a check on the footwear that a person prefers to wear while doing any kind of physical activity promotion program, or whenever we are going to teach any kind of physical activity promotion in these population? Do you think it is important?
I don't think we have any evidence. You said you said as it was the truth that there is a connection with posture, but do we have?
I do not know. I do not know. But do you think any? I mean, I'm
very skeptical towards all these things coming from general physiotherapy, and we take it into the pelvic floor as it is the normal thing. In my experience, women with incontinence and the gymnasts, they have very good postures. I mean, the rhythmical gymnasts, the dancers, they are straight. They have this problem. So in my theoretical understanding, I can't see how. I hope we are talking about the same. We're talking about posture. I think I'm talking about the curvature of the back and how you have the tilted the pelvis or not. I can't, from my practice, support that theory that it is a connection, because I see all these fantastic dancers and others, and they have incontinence.
Yeah, my question was, ma'am, on what if there is a pronated foot or a supinated foot, the ground reaction force that can impact the pelvic floor. So what kind of footwear they're wearing during an exercise session, can it also matter?
I think there is one study from Ingrid Nygaard. She's actually married to an orthopedic surgeon. So they did the study together and they found some association, but that's the only study. And I think, again, I think you have a good research question, and I hope that you can follow that question, because this is what we need to really study. And it may be so that it will be a different ground reaction force depending on that. But again, there are so many factors in play in this. So how can we say that this is the cause and this is not the cause? It's very, very hard, and you need a huge number of participants to see and to have them in different groups. So some pronated, some supinated, some normal, and to be blinded for those having the hypothesis, and to do that in a very proper way. I think it's a difficult study, but it's an interesting question.
Yes.
Yeah.
Thank you for your insight. Ma'am?
In our country, episiotomy is done pretty routinely for every vaginal birth. And I don't think in the Western world, episiotomy is done in selected cases, as I've understood. Have you found any difference in the pelvic floor function or dysfunction in a patient who has had an episiotomy or who has not had an episiotomy after the delivery?
We did one study on that, and we didn't find any significant differences, but I think others have found it. So I think, again, this is a new field of study, and we need more studies. It's always bad to say that, because we can't really come with any good conclusions, but I think it's the truth. And also, episiotomy is very different from country to country, where you put it and when you do it. And I mean, there are all different risk factors that is into play. So when you not to do it in Norway, we don't do it routinely. So it's only in case the midwife think that something will happen, they do it. So, and it's never midline. is always mediolateral. So again, we need to be very sure of what we are studying and look into that. But again, need more knowledge.
Yes.
But we didn't find it in our study from Norway.
Thank you. Thank you.
Dr. Nilma, ma'am. Ma'am, in your clinical experience, ma'am, you would have come across many women, either young or old age women, who have difficulty in understanding the instructions that we give. For example, the lift, the squeeze and lift techniques, and even if you do an intravaginal palpation and ask them to activate the muscles, we find sometimes difficult. They don't understand. So have you come across that situation, and how have you dealt with this situation, ma'am?
Yes, I feel that's very important because so many times in the first session, they may not understand what we're talking about. About 2% of the women might be that way. I could come across. But then what I do is just tell them what it is, ask them to observe themselves and come back after a week. So we can ask them to just close the lips and gently try to blow out. The minute you do it, you will feel the activity at pelvic floor. So we are closing the lips and then try to blow out gently. The pelvic floor gets activated. So there are many ways how we can train them, and don't even label them that they are zero or they are not able to activate, and give them that this is the way how you should be doing. And it works. So in the next visit, they would come up and they would understand. That's what so ask them to just stop the urine flow. So they'll get connected to this. And after a week, they'll come back and we see that there is a difference and they get connected to the muscle back again. That's what I have found. Very few women, of course, but yeah.
Yes. Mirror feedback. What about your opinion on mirror feedback, ma'am?
Women don't like to use. That is the basic thing. They don't like to see themselves in the mirror like that. So we have to check whether they would be liking to do it. But that's the wonderful way. Even for our students, I say that you do it. See, unless you do it and you feel free to do it, then only you advise. So because that is one area they would not. And here women, our students don't like to, do on each other and things like that. So I say, to understand this, you see for yourself, you feel for yourself, and then you do on someone else.
Thank you, ma'am. Thank you.
Fecal gas leakage is a very embarrassing problem. If they have urinary incontinence, we advise them sometimes to wear diapers, and that protects them. Is there anything that they can do for gas leakage, involuntary gas leakage? Other than, of course, exercises, but anything they can wear? Have you come across this?
I just know that there is there's something that you can put into the rectum, but it's been used in the Netherlands, and I think it's, I don't remember the company that make this. So it's something that you can put in that should avoid leakage, but I'm not sure if it's really working so much for gas. And also the studies on anal incontinence, including gas, they are not conclusive for the moment. The Woodley study that was looking at this during pregnancy and after childbirth, they found only 6 randomized control trials, and it was inconclusive. So again, we need more studies. The last study we did in Iceland with a randomized control trial in postpartum, we didn't find any effect on anal incontinence in that study. So I don't know more than that.
Thank you. Thank you. Dr. Bedekar, do you have any experience of this?
No, actually. Fortunately, I didn't get so many women with this, and they didn't speak out. Maybe they might have this problem, but it's
a very interesting problem. Yeah.
It is a genuine problem. So sometimes even the vagina, like that is also there, air in the vagina and things, which can be overcome. But this, I haven't come across many women with this problem. I feel tightening the pelvic floor does work for some time, but not all other times. So they don't come back saying what happened. So I do see that you squeeze in and you sit at one place and try to accommodate at that time. But if the person is standing and doing things, then it may be slightly difficult to do. So that is one area we need to check through what else can be offered to these women.
Thank you. Rita?
Ma'am, you're on mute.
Muted. Preeta, you're muted.
Sorry. Are we on, like, we have done with the time? I would just like to ask the moderators.
Ma'am, we can have one more question if you would like to.
All right. Shall I ask one more question? I think we are in such a situation here. We would like to just keep on asking and, you know, having more discussion. But yeah, we have our own time limit. Dr. Kari, in a recent narrative review, the one that is recently published in 2020 in Sports Medicine, there was a striking but very important statement, I thought, was there may be an individual threshold of intra-abdominal pressure related to each individual's harm-benefit ratio. It was a very, what do you say, enlightening kind of thing when we read it, because for each person, there may be a threshold. Yeah. So what, can you add your insight more into this? Like how could you think about such a powerful statement? And, you know, it was a real eye opener for many of us.
Yeah, I think it's really based on the studies that I showed that has been done during ground reaction forces and also intra-abdominal pressure, that you can see this huge variation between the studies and also between activities. So it certainly is. I don't think we will find one threshold for anyone. It's but I think it is as difficult as that, but we must never forget that you gain more for being physically active than being sedentary. So we should never get into a more sedentary life than what we have, because that's the big problem in the world, all over the world, is that we are becoming more and more sedentary. So we can't use the pelvic floor, I think, as an argument not to be physically active. We just have to deal with the pelvic floor during physical activity. And since there is this huge potential, as I already said, for improvement by doing peripheral muscle training, and it hasn't been tried in women who are physically active, I think that's the way to go. And throughout my career, this has been my really main focus, not to make women stop exercising, but do the pelvic floor as well. As why do we do gluteal muscle training and abdominal training and not the pelvic floor? It's because we don't see the muscles and we don't know where they are. So, but still, this is not muscles that has anything to do with the appearance, and we are so really stuck into appearance exercises instead of doing exercises that are functional and important.
Absolutely.
I think.
Absolutely. You said it.
But I think it's so interesting that this has been part of yoga, and you have a lot of yoga in India. So, because I'm not an expert at all in yoga, and personally I don't like it, but I have seen in some of the books that they are talking about, and it's contraction around the anal canal. So there is the pelvic floor. So that's very important that you have that in your system, and you could develop and do that properly during a yoga class, because general yoga exercises wouldn't help, because general exercises doesn't help. But doing that into a yoga class where women exercise anyway, that's also one of my main messages. So I teach aerobic classes twice a week, and I always include, during the strength training, I have a session of pelvic floor muscle training, just as we do abdominals and gluteals and other muscles and biceps and triceps and all the other things. We do pelvic floor muscle training. That's the main thing. And I think that if we could do that in all women's exercise classes, at least we would reach out to a big population of women.
Yes.
Thank you so much. Thank you so much.
Thank you.
Thank you very much for inviting me and for also organizing this in a very, very, very good way. Thank you so much.
I would like to thank our esteemed speaker, Dr. Kari and Dr. Nilima ma'am, for such an enlightening and amazing session. I would also like to thank our honorable panelists, Dr. Snigdha Mehta and Dr. Preeta. Thank you so much. I would also like to thank our team, Dr. Ashok Sham sir, Dr. Rahul Chaube sir, Dr. Apurva Shimpi sir, Dr. Neeraj Athavale sir, Dr. Manish Ray sir, Dr. Amruta Poddar ma'am, and all the members of the Physio TV. Lastly, I would like to express my gratitude to our attendees who have played a vital role for making the webinar successful. Looking forward for your support in the upcoming webinars as well. I, Farheen Patel, sign off for the session. Stay happy, safe, and goodbye.
Thank you. Thank